with this, I'd like to invite Dr. Ajay Purohit, who will talk to us about my learnings through SFIOL surgery.
Good morning, everyone. I would like to thank Dr. Hitesh sir for giving me this opportunity. I would like to discuss my steps of SFIOL, which I do, and the learnings which I've done from SFIOL. And these steps do a stepwise. First, we do the incision making. So incision making for the routine SFIOL, I prefer routine SICS incision, which is there. And for me, it's a very comfortable incision. It's give me a good area to maneuver the lens. But in sometimes, this is a routine. Make sure that it's around 5 to 6 mm so that IOL insertion is easier and do not hustle during IOL insertion. So this is a routine SICS tunnel which I usually make. You can see the dislocated lens which is there, and sometimes we need to reopen the SI system. This patient was operated a week back for a subluxated lens, and anterior vitrectomy was done. Now after 1 week the patient presented to us and we planned for an SFIOL. So I just reopened the previous SICS tunnel. I did not make any new tunnel. You can see that there's some difficulty in opening the tunnel, and because of the fibrosis which is there, but ultimately I was able to open the tunnel, and this made me not to make a new incision. There was a pupil dilation, and this patient, he had already done an SFIOL. He presented to us, and there was superior fibrosis which was there. So I planned to go for a clear corneal temporal incision to explant this IOL. So incision is not just only SICS easy incision you can get these patients also, which previously operated cases were there. So you can see the knob is there, which this patient has already undergone 2 secondary IOL surgeries, and he was implanted with a CMT flex IOL, and a small eye, colobumbatous eye, and all throughout almost 270 degrees the fibrosis was there. The cornea was already involved because of the previous surgery. So this time I did make an SICS tunnel, but because of the fibrosis, the tunnel making was not that easy. So we need to counsel the patient. We need to do a good preoperative corneal evaluation also, and corneal decompensation chances are always there. You need to counsel the patient first. So ultimately, you can see the knob of CMT flex which was there. And for infusion system, my preferred practice is going for a pars plana infusion system. But if you're an anterior segment surgeon, you do not confident for pars plana incision, you can also go for a AC maintainer. So this is how a routine pars plana infusion system does work. This is my preferred technique, but for anterior segment surgeon, you can always go for a AC maintainer also. It's always important to maintain the AC during this SFIOL thing. My preferred techniques is I use a XNIT and a Yamanase mixed technique, which is a modified XNIT or a modified Yamanase technique. In this, we go for an oblique tunnel around 1.5 mm from the limbus, and we guide the 26 gauge needle through the superior SICS tunnel. This guiding is important. You need to use your forceps to guide, or it will damage the cornea or the root of the iris. And then the leading haptic is rail tracked into the haptic, and the IOL is slightly pushed into it. And just make sure you do not come out very quickly, or the haptic you lose the haptic. And just with the help of the stopper, just pull out the needle, and that's it, the haptic is out. And just make sure you do not pull the complete haptic out. Make sure the part of haptic is out, because it will help to easily maneuver the trailing haptic, or else there won't be any place to maneuver. So when we put the leading haptic, pulling the leading haptic inside, make sure the 26 gauge needle is in extreme of the tunnel. Do not make it sit at the middle of the tunnel, because then maneuvering the haptic will be more difficult, and will end up breaking the haptic or bending the haptic. So just pull the needle to the extreme end of the tunnel, slightly, very gradually catch the haptic, and just rail track into the haptic. Only the 3 to 5 mm of haptic into the 25 gauge, and just pull it out, and that's it. And just the haptic won't go anywhere because it's a oblique tunnel which you have created. Now we can always cauterize the haptic. Cauterizing will make a mushroom shaped tunnel at the of the haptic. You can always use a electric cautery or a heat cautery. I've used a heat cautery here because then that day the electric cautery was not working. So heat cautery is also always handy to use. Make sure you don't touch the cornea when you use a cautery. The terminal bulbs need to be flat enough, or it should be like a tabletop, or should be mushroom shaped opening, so it doesn't fall off the 26 gauge track which we have created. You see that bulb, it needs to be, it should not be haphazard, or it will irrate the conjunctiva and come out post operative period. Same do with the other haptic also. And just push the haptic, and you see this knob, it needs to be a good knob and a flat knob, not a rigid knob. Just push it subconjunctivally. Sometimes you can also do a localized peritomy, push the haptic and just pull the conjunctival back up and suture or glue it the conjunctiva, so that you are sure that it's going subconjunctival only. Or as post-operative, find the haptics going coming out of the conjunctiva, the patient will complain of foreign body sensation. So if you see these things, the results are, these are immediate day 1 post-op periods. This is subluxated lens, this is well centered, which is there. 6-9 vision, first day post-op, corneas are clear. The haptic, the knobs are subconjunctival, there is no exposure of the knobs. This again the coloboma eye which was done, the CMT flex subluxated lens, and then the first day post-op lens is centered. And this is the traumatic lens which was well centered the first day. Thank you.
Thank you, Dr. Ajay. Just like to want to know what is your reason for using this particular technique, for what is your advantages that you find with.
So one advantage which I actually find is that the maneuverability is easy. We are maneuvering the IOL outside the eye. It's not inside the vitreous cavity. Some surgeons, beginning surgeons, can have problems maneuvering the lens which is inside the mid-vitreous cavity or inside the eye. So this time in this technique the lens is outside, and we're just maneuvering the lens from outside only. Second, the dissection part reduces. Making flaps for SFIOL, the dissection part actually goes down. The time of surgery actually goes down. If everything goes right, the surgery will take around 20 to 25 minutes, and the post-op days results are fine. The patients are extremely comfortable, and I have almost 2.5 years of follow-up of patients. They're extremely happy. There's no IOL, the haptics are not exposed, no end-off, and patients are extremely good vision.
In the presence of ports, when you're doing vitrectomy, along with which invariably you may be needing in most of these cases, does those ports have any kind of do they hamper your movement?
Yes, definitely. These ports do hamper. You need to be very careful. Or sometimes if when you are about to implant the lens, just remove one of the port, especially the superior temporal port. Just remove the port, implant the IOL, and then reinsert the port and complete your vitrectomy. But this is one thing which is actually there, which the practical problem which actually happens.
Any comments from the audience? Yeah, Divyansh.
Such cases, one of the issues that what we was listening to circle is they can have exposure of the haptics or a part of it which can be exposed. So in those cases, what we have done is utilize the green laser itself. So the green laser cauterizes that and then it retracts back inside. So we published that also. It is very easily how we do a focal laser. Use a single spot, either 100 microns, spot size, or maybe around 100, 200, and duration 20. And it very well retracts into the conjunctiva without doing the surgery.
So when you do that, when you retract, when it retracts, when you cauterize, or when you do these maneuvers, does it affect the tilt? Does it cause any astigmatism, or does it move inside? No.
Not really, sir. There's no tilt. I will keep it stable throughout the day.
In my practice, I usually use 4-point fixation IOLs like AIOC, and I find it to be quite stable once you have the initial, but your initial measurements and alignment has to be very good.
So the 1.5 to 1.75 from the limbus is actually important, or it will lead to optic capture.
Right.
The iris will get captured, so the distance is
One of the reasons why the tilt occurs in this case is because if you have not centered or both the alignment of the ends, like the haptics, whichever are at the bulb, if one is little tilted also, that will cause an option effect on the lens, and that is what in my cases the the maximum till I have seen because of that is 3 diaphragm, which patient was okay, so I am still continuing.
So I just had one more question over here. So if let us hypothetically you put an air bubble or something, and then will that cause a chill? The reason I'm asking is that there are times when we do it along with our consciously, when we want to do a TMA or a DSET along with a secondary activity. At that point of time, one of the concerns they have with technique is that when they put an air bubble after the DSET, the IOD can not be developed. So any experience with that?
I would have done PKs also, open space, but in those cases, still if I have wrongly calculated as I was suggesting that if I'm not exactly 180 degrees apart, then a little less air would cause a little dip. But once the air gets absorbed,
so it's controlled.
go back to the same shape. So it doesn't.
I think better to avoid.
Better to avoid that, but otherwise put the visco and nitrate into some time and then.
But with the DSEC, we can't put visco. The air needs to be there. But it's just a temporary tilt, sir. It's just a temporary tilt. I've done
Exactly
2 cases, just a temporary tilt. And the time air absorbs, I will again.
So I've also done it, but every time when I do it, I live with a small fear that this may happen. That's why I'm asking anybody has got more experience.
No, so I don't do SFIOLs. I stopped long ago. But even if externally you think that you are perfectly aligned, 180 degree apart, equal distance, sometimes the problem is inside when there's part capsule, part vitreous, one side, and that one, even if from outside everything is aligned, inside everything is one will be, there's no space for the IOL to be in the correct centration position, and if you don't tackle that, whatever you do, you may end up with problems. So that is something very crucial even for SFIOL surgeons who are, that you must do the anterior segment reconstruction properly, make sure that there is space for the IOL to be equally aligned on this.
This is a very good technique. The thing is, I've done once only. After I did it, unfortunately, the next was decent. But the subluxation.
You got a subluxation or not?
Decent. But the one happening was more experience than the other one.
Yeah, it can bend the haptic, and sometimes it can slide back a little. It can move a little. So that risk is.
Make the double exactly at the same place.
Yes, sir. That is the thing. And even if when you are contrasting the haptics, so you need to be careful that you contrast almost the same thing. When contrast one more and one less, it will go like this. And the post-op period, you will find a haptic popping out of the control.
So what Dr. Mudit was saying, and what coming out of discussion also, was the reason exactly why I have never really been a big fan of this technique. Like a sutured SFIOL, this has only a 2-point fixation kind of a. It's hanging on that cautery edge, or earlier we used to hang it on the suture. Vis-a-vis when you tunnel and tuck that IOL, a length of it inside, it becomes a little more stable
we
into
can
the
do
sclera.
like this also. Only there you can use the needles to externalize the haptics. You can make a tunnel, tuck it in, and
so when you have a little broader length into the sclera, it gives it a little more stability. And in that cases, even with DSEC eyes,
it will be more stable.
It is more stable. It doesn't turn with. And what Dr. RN was saying, I have actually cancelled quite a few SFIOL after doing vitrectomy and examining the ciliary body area, and I have found either from a previous VR surgery, some anterior segment PVR, neovascularization, or an unhealthy ciliary area where I know implanting an SFIOL actually may be a more harmful thing, and I've actually not done it. On table also taken that call and not done it.
That's very, very crucial, that if you don't have enough space over there, you will have the IOL one part coming out and decentered.
Or it may bleed during surgery, post-operatively, so all those
And
things.
sometimes
One more point to add to that will also be conjunctival fibrosis. So before planning for an SFIOL or a blue diet, also becomes important to assess the condition of the conjunctiva. The patient is already undergone multiple surgery. Sometimes you may find the entire conjunctiva fibrosis, and there is no place for you to maneuver. So you either need to make a placement or entry in an alignment which is away from the liver fibrosis, or probably not do a second diet.
sometimes we are lucky that actually if we are open mind, instead of just saying I'm going to do what I have planned earlier, but you go and see there is sometimes substantial capsular support already there. You can put it as a 3-piece IOL right in the sulcus itself and not struggle with the other. Yeah. If the iris is there, there are so many other options. Iris fixated IOLs are also there.
Okay, thank you so